So yeah, thank you for coming to the education session today from Virtual Specialist Consults. We cover across Victoria and around the border regions as well. And what the service is trying to do, if you haven't come across this before, is really focus care in the community by linking in people in GP or other primary care providers as well, with hospital input to manage cases that ideally prevent somebody to come into ED or hospital, or or prevent a really long wait to be seen for something which can usually be sorted out through a discussion. I think one of the best things, which is why I first became aware of this as a GP, is that. Oh, sorry, I'll just mute everyone there.
I've always wanted to make this, but I never did.
One of the reasons I found is the best way to use it, if you can, is that co-consult or case conference where you, as the GP and the hospital doctor and or someone else like the nurse or diabetes educator, are all there together, and you're having these live discussions with the patient, sharing notes and information. And so, my health record doesn't have something, but one of you does, you can share it immediately, which is great, and make joint decisions. We've also got it credited for CPD for each time that you do the COAS conference. So if you're a GP, you can write a reviewing performance and submit it, and that'll give you one RP for CPD as well. Very excitingly, on the website, you'll see there's been a steady kind of expanding of clinic times and availability. And this week, e-consults has become available. And what that is for some of the clinics, and I'll send out more information, you can send a message to one of the hospital teams, say like to Matthew from haematology as an example, saying, well, this is a generic situation I've come across. I'd just like some advice. So we try to keep it a bit de-identified. All the instructions are there, and you get a 3-day turnaround on the answer. And it's more for, you don't need a specific thing about a specific patient right now, but if you just have something which has been niggling at you or you just need a bit of extra help, then the e-consult service is a good asynchronous way to talk. And we're always open to feedback as well. So without further ado, I'll hand over to Matthew, and everyone who is here who's from ACRM or CGP, we'll make sure you get your CPD points as well. And any questions throughout, might let Matthew decide if he wants to take during or after, but we usually say hold them until after. If you want to write them in the chat, I'll monitor it. And thank you all for being here. Thanks, Matthew.
Thanks. Did you want to do the welcome to country, Morgan?
Yeah, of course. So wherever everyone's joining from, so we at Northern Health and at Victorian Specialist Consults as well, the Virtual Specialist Consults, we acknowledge the traditional custodians of the land on which our health service is built, the Taungurung and the Wurundjeri people, and we acknowledge their continuing connection to land, waters and community. We pay our respects to the people, the culture and the elders past and present, and we extend that to any lands that you're on today as well. Thanks, Matthew.
Thanks, Morgan. And this is just our availability for everything here, which I can't speak to specifically. This is just some generic introduction about myself. So as Morgan said, my name's Matthew, one of the haematologists. I work at Northern Health predominantly, as well as at Eastern Health and privately in Coburg and Richmond. I really like looking after myeloma and lymphoma, but also do a lot of general haematology as well. I know everyone's from different places in Melbourne, and not everyone specifically is in the Northern Health catchment area, but I just wanted to quickly give a plug to our haematology unit at the Northern, which has got a great group of young haematologists, and we're trying to look after the people who live out in the northern suburbs and give them access to all the specialised treatments that are available now for complex hematologic disorders. So we really like looking after patients locally so they don't have to travel, half an hour into the city unless it's really required. And then we have those links for those specialist services. So I consult at the virtual specialist clinics on Thursday afternoon, and really our goal is to manage a lot of low acuity hematology issues, provide some advice and take that burden off our specialist clinics, because it's very difficult to keep up with a lot of this, but also to explain to the patients that generally there's nothing to worry about with their minor cytopenias, and get it sorted out in a timely fashion rather than waiting for months on a wait list. So we've got two other great haematologists, Dr. Maddie, who's another general haematologist, and Dr. Brooke, who's a hemostasis thrombosis expert, and they consult on 2 other days throughout the week. Just quickly, I saw this at the start. I think this might be AI generated, but there's 2 issues with this photo on the right. The first is the patient looks very anemic. I've only ever seen blood like that once when a patient's hemoglobin was 2. And the second is, in Australia, we generally collect FBEs in a purple top EDTA tube, not a blue citrated tube. But only a haematologist would care about that.
I'll take the flak for getting that one wrong. Sorry, Matthew.
That's okay. So today I'm going to try to talk about common FBE abnormalities, predominantly low blood counts, because that is probably 90% of the things that we deal with. And if we deal with it, it probably means that it's what you're dealing with as well. And trying to understand the basic workup for these, and just, I guess, some reassurance about the fact that a lot of these mild cytopenias we see are nothing really to be scared of and turn out to be nothing, but try to get a sense.
Matthew, I think you might have gone on mute by accident. That's all good.
Great. So I don't have specific pediatric hematology training, so I won't specifically be discussing about that, but a lot of the same principles will apply, especially as it applies to neutropenia, which I know is a common issue in pediatrics. Just as a bit of background, because I work as a laboratory hematologist as well, there's a lot that goes on behind the scenes before you get your full blood count. So this is just a stock image, but this is the Alinity FBE analyzer that we use at Northern, but each analyzer is slightly different. And it's actually quite complicated the way the machine works to give you those numbers. I guess what I'd say is there's a lot that goes on behind the scenes for us in the lab to try to diagnose most hematologic problems without the clinician trying to think. And I guess that's because when you see a patient with fatigue, you're not expecting them to have acute myeloid leukemia. So we kind of see it as our onus in the lab to pick up the majority of those things. And there's flags based on the full blood count parameters of when to generate a blood film, and also based on various morphological flags that the analyzer has to try to pick up these cases and trigger a blood film review that initially gets reviewed by a scientist and then pass on to a hematologist. So even though you can technically request a blood film, often the lab will do that automatically, and some labs will, even if you request a blood film, won't go on and process it if they don't think it's worth their time. That's not with any of the labs that I am with. At Northern Pathology, we'll always make a blood film, but I know some of the bigger labs probably can't keep up with the demand for blood films. So if you ask for a blood film and everything's normal, they won't look at it, unfortunately. So the first cytopenia is anemia, and each lab, like most cytopenias, will have a slightly different reference range, but they're listed there. There's no specific reduced reference range for hemoglobin in the elderly. However, anemia is more common due to those factors there, specifically renal impairment and low-grade inflammation, chronic diseases such as heart failure, liver failure, renal impairment. And there is this concept of unexplained anemia of aging that is a diagnosis of exclusion. And, we don't commonly make this diagnosis, but you've probably got patients out there who are, in their 80s or 90s who are just sitting along with a hemoglobin of 110, 120, and chronically a little bit low. And it's probably a little bit of renal dysfunction as well as low-grade inflammation. The most important thing with anemia is really looking at the red cell parameters. And the 3 most important ones I've put an arrow next to that I look at are the hemoglobin, of course, the mean cell volume, or MCV, and probably one that you are less familiar with is this red cell distribution width, or RDW. And so we'll go on the breakdown of anemia by MCV, but in certain cases, the red cell distribution width can also give us a little bit of a clue. If it's normal, it suggests that all the red blood cells are relatively similar in size, whereas if it's increased, it suggests there's a variation in size of the red cells. So when I see this pattern of a macrocytic anemia with an increased red cell distribution width, it's very suspicious for myelodysplastic syndrome already. And this is one of my patients with myelodysplastic syndrome. So when you see someone with anemia, the first thing and most important thing, like all cytopenias, is to look at the other parameters, to look for other cytopenias and look at the trend over time. I must admit we have a bit of an unfair disadvantage that I have access to a lot of the pathology companies' historical blood tests. So at Melbourne Pathology, Dorovich and Clinical Labs, they allow haematologists and some other specialists to look at blood tests ordered by any prior provider, and that can really give a great sense of how long this has been going on for and what the trend is over time. The minimum really for anemia is iron studies, as you'd know, B12 plus or minus folate, and a myeloma screen. I'll talk a little bit about thalassemia, but hemoglobin electrophoresis can be useful if they're microcytic, and hemolysis markers if you're suspecting hemolysis. And when would we suspect that? Well, if the bilirubin's a little bit elevated, if it's a normocytic anemia. So in terms of microcytic anemia, 99% of the microcytic anemia you'll see is iron deficiency. So if anyone's MCV is low, the first thing to do is to check the iron. If it's normal, it's probably some form of hemoglobinopathy or thalassemia, and I'll talk about that in a minute. There's also patients who have what we call functional iron deficiency or anemia of chronic disease. Most of these patients are normocytic, but in severe cases, they can be microcytic. We tend to see this in hospital, for example, people with very active cancer, very active inflammatory bowel disease, or recent surgery. And then there are very rare causes that you will probably never see, and I don't think I've seen any of those. So with regards to thalassemia, the first thing we always do is look at the historical MCVs, because if the MCV has been normal on at least one occasion, this largely excludes thalassemia. And, you know, if someone's had a normal MCV previously and it's now low, that is almost diagnostic of iron deficiency, even without iron studies. And you may have noticed that iron deficiency, especially when it's severe, can cause a reactive thrombocytosis. You probably manage a lot more iron deficiency than I do, so I don't want to try to teach you things that you probably already know, but we do see people who have iron deficiency, and sometimes it's suboptimally managed. You know, of course, in younger women, menstrual blood loss is the most common cause, and I'm generally a fan of using some tranexamic acid. That's just because I'm something I'm very familiar with, and it's easy for me to prescribe. There's very minimal side effects, and on average, patients notice an improvement in about 30 to 40% reduction in their menstrual blood losses with very minimal side effects. Oral iron, you know, it is difficult for some patients, but whenever I see people who say oral iron didn't work, I want to make sure, number one, that they're using a therapeutic iron treatment and not this stuff that you buy at the chemist, which is often does not contain enough iron to actually treat iron deficiency. Then if they've tried it before and they really find it intolerable, sure, intravenous iron is a good option, but you know, even in hospital, it can, even for outpatients, it can be an issue for us to organise in a timely fashion. So I will still often encourage people to try oral iron and just use an escalating dose schema like this. We know that second daily dosing is a lot more well tolerated than daily dosing of iron. Probably doesn't matter if you take it with vitamin C. There's now some evidence that it doesn't really improve the absorption. So thalassemia is very complicated, and I must say I don't think I really understood thalassemia until I did lab hematology training. Essentially, it's a disorder where there's reduction in the amount of hemoglobin chains synthesized, and the typical presentation is a chronic microcytosis or hyperchromia with often a mild anemia or slightly lower than normal hemoglobin, and the iron is normal. It's difficult to diagnose thalassemia concurrently with iron deficiency. Therefore, we try not to do it unless the patient is pregnant. The good news is that most thalassemia diagnosis is not really that important, except in the setting of pre-pregnancy counselling. So this is an example case. This is a patient with MCV of 64, so definitely microcytic, and a very mild anemia of 110. And the ferritin is normal, so they're not iron deficient. So even without electrophoresis, you can say the patient has thalassemia, really. Now, the hemoglobin electrophoresis is completely normal, so hemoglobin A2 is normal. So this excludes beta thalassemia. Alpha thalassemia can only be diagnosed with DNA analysis. So this result is in keeping with alpha thalassemia, a presumptive diagnosis, but then confirmatory testing with DNA analysis is required to confirm the diagnosis and I guess help to prognosticate what the risk in the pregnancy setting is. So this patient was Filipino and had the typical Filipino deletion where it occurs on one gene, so it's often co-inherited and there is a risk to the child. So normocytic anemia, still don't forget about iron deficiency. Often, especially older patients, their MCV will sit up in the 90s, and then when they become iron deficient, they'll just drop down to the 82. So you can just look at their previous MCVs, and that can sometimes give a guide. Renal anemia, obviously, anemia of chronic disease, hemolysis, although it's really not that common in the outpatient setting, and the lab should flag most cases of hemolysis. And myeloma is the important thing to exclude. Any bone marrow disorder can theoretically present with normocytic anemia, but it's much more likely to be macrocytic anemia. So then we get to macrocytic anemia. There's very few things that cause this other than B12 and folate deficiency, drug effect, liver disease, and alcohol. And then we really start thinking about bone marrow disorders. And really, if you've got a significant macrocytic anemia that you can't really otherwise explain, it's usually going to be a bone marrow disorder. And you may still observe it, especially if they're older, but they may have an underlying myelodysplastic syndrome or other bone marrow disorder. So these are my just guidelines. So you don't have to refer. If patient's anemic, I would generally just treat the iron deficiency first and see what happens afterwards. If they've got, for example, known beta thalassemia and their hemoglobin's about 105, 110, sometimes we get these referrals for patients who are tired. Unfortunately, that's just what their hemoglobin is. If you have a patient, especially someone who's older, who's just below the normal limit of hemoglobin, so sometimes for men like hemoglobin of 125, for women just under 115 to 110, everything else is completely normal and you've excluded myeloma, we would often just monitor those patients. So you could just monitor them as well. On the other hand, we worry about progressive lowering, unexplained macrocytic anemia, especially if there are other cytopenias that you can't explain, and an abnormal blood film. So this is case one. So I looked after this patient I still do, but he first presented last year. So he's 85, very non-specific symptoms with his GP. And I think he actually went to a geriatrician as well. He just had a mild anemia that's normocytic, but bordering on macrocytic. The white cells were normal differential, platelets are normal, blood film normal, mild renal impairment, so maybe it's renal anemia. And the GP is very smart and thought about myeloma and did an SPEP, which was normal. So in summary, it's 85-year-old man with anemia and mild renal impairment who's got some non-specific symptoms. Just have a think about what you'd be thinking about. So just remember with myeloma that if you just do a protein electrophoresis, you'll miss around 20% of myeloma, which is light chain only. So one thing to remember, in unexplained anemia, always exclude myeloma. To exclude myeloma, SPEP and light chains. You don't necessarily have to do a urine protein electrophoresis. If you do an SPEP and light chains, you'll pick up 99-point-something% of myeloma. Interpretation of protein electrophoresis and free light chains can be confusing sometimes. Some of the labs have good interpretive comments, other ones less so, where any abnormal ratio they will say that's suggestive of myeloma, and often slightly abnormal ratios are not suggestive of myeloma. They can be normal, especially in patients who are older with renal dysfunction. So such cases, if you just want help with interpretation of light chains, for example, I think a virtual specialist clinic consult is a great option. And most of the cases we can say that's just normal for given their age or renal function, and not to worry about myeloma. And myeloma is important because even this patient is 85, very treatable with modern therapeutic approaches, even in very elderly and frail patients with good treatment and good supportive care. There's lots of novel treatment options. And although we don't have all treatments available in Australia, we kind of expect that or hope that patients diagnosed today can live a near normal life expectancy. Not everyone, but many patients. And this is a graph of survival by era in myeloma. And this red one is the last decade. And the current decade is likely to be even higher than that. So on average, myeloma patients are living 10+ years. If you have any questions about anemia, I'm happy to answer them now. Otherwise, we can move on and we can just answer them all at the end. All right, I'll move on. Neutropenia. I'm sure you all love seeing neutropenia, as do haematologists. So this is how I break down the severity of neutropenia. Definitely severe is less than 0.5 and moderate 0.5 to 1.0. The textbooks would kind of say 1 to 2 is mild, but honestly, 1.5 to 2 is really, I consider it just borderline low. And the thing that's important about neutropenia is if it's isolated mild to moderate neutropenia, which is most of what we see, the vast majority is benign and not associated with any increased risk of infection or other bone marrow problems. But it causes a lot of angst. So when we think about the causes, certainly infections, especially viral infections, we can see this. And I would always just exclude hepatitis B, C, and HIV for people with neutropenia. Just make sure they've had it done at some point in time. Drug-induced neutropenia, I will talk about a little bit. True cyclical neutropenia is very rare. True cyclical neutropenia is when patients' neutrophils drop very low, usually less than 0.5, and then recover in a cyclical fashion and then drops again. And usually when it's low, they are severely low and have mouth ulcers. It's very rare, and I've not seen a case. The majority of cases of neutropenia, we end up with either no diagnosis or putting them into the basket of immune-mediated neutropenia or benign neutropenia. And I will talk about ethnic neutropenia in a little bit. Serious causes of neutropenia are thankfully quite rare. If we think about isolated neutropenia, there certainly are congenital neutropenia syndromes that predominantly present in childhood. Theoretically, things like myelodysplasia and acute myeloid leukemia can present just with neutropenia, but it's quite rare. And they will usually have macrocytosis or a blood film abnormality. There are very rare lymphoid disorders, the two major ones being hairy cell leukemia and large granular lymphocytic leukemia that can present with isolated neutropenia. And theoretically, any bone marrow disorder can present with any isolated neutropenia, although there would typically be other cytopenias. So the problem with medication-induced neutropenia, like medication-induced thrombocytopenia, is if most drugs have been associated with it. So I've just kind of listed the ones that we commonly see, and this is non-chemotherapy drugs. Obviously, patients having chemotherapy can get neutropenia. So obviously carbimazole, the antithyroid drug, which can cause both a dose-related mild neutropenia as well as a more rapid onset agranulocytosis. Valproate is quite a common one. It causes many hematologic abnormalities, thrombocytopenia, and sometimes macrocytosis as well. Obviously, clozapine is well known to cause neutropenia, but there definitely is some crossover with the other drugs that are structurally similar to clozapine, such as olanzapine. Rituximab can cause a delayed neutropenia after the rituximab has stopped, generally 6 to 12 months after, if you have any patients receiving rituximab for any reason. And most of these reactions are idiosyncratic, unfortunately, and in your typical older patient, it can be difficult to ascribe what's causing what, but it can be easier, in the younger patients who are just on one drug. So workup, the most important thing really is the FBE parameters, looking at other cytopenias and historical FBEs. All neutropenias, I will look back at their historical blood counts, if available, and often you'll see that they've had mild fluctuating neutropenia for many, many years, and you can show them that and reassure them that, if you had leukemia, it would likely have been getting worse over the past 10 years. Often we see this pattern where the neutrophils, sometimes they're 1.5, sometimes they're 2, sometimes they're 1.4, and they just kind of hover in that low normal range. At a minimum, I would generally just make sure that they've had their hematinics and viral serology at some point in time. And then I generally just do an ANA. If it's positive, it supports the diagnosis of immune-mediated neutropenia. And then it would trigger me to look for whether they have true lupus. When they come to me, if they're starting to get down to 1 or maybe below 1, I would consider doing peripheral blood flow cytometry and myeloma. I've probably seen several hundred neutropenias over the past year or two, and I don't think I've seen anyone who hasn't had something else like macrocytosis or another cytopenia with neutropenia who's turned out to have any serious blood disorder. But obviously it can happen. So certainly mild chronic neutropenias who are asymptomatic, you don't have to refer them to see a hematologist. By the same token, if they're really anxious about it and it makes them feel better to hear an explanation from someone who sees a lot of neutropenia, then it's something we're happy to provide. The virtual clinic is a good option for people like this. And if you refer someone with neutropenia to the Northern, we triage all such patients straight to the virtual clinic so we can see them. I'm more worried about older patients who've got more severe neutropenia. If there are other cytopenias, macrocytosis. So this is my case report. This is a real case. Pre-IVF bloods, and her fertility specialist told her she couldn't have IVF because she might have blood cancer. So as I said, most important thing is looking back at the trajectory and what's happened over time. And you can see, like clockwork, every year she has her bloods and every year they're just slightly low. She's completely well, Egyptian background. So in this case, just to prove that fertility specialist wrong, I did the Duffy group phenotype, which you can request at the lab. So this is a clear case of Duffy-associated neutrophil count, or what we used to call benign ethnic neutropenia. This is a condition associated with the Duffy null red blood cell phenotype, which protects against Plasmodium vivax malaria and is associated with a lower than normal white blood cell count, down to 1. Sometimes I see patients a little bit lower than 1, like 0.8, but most patients are in this 1 range, 1 to 2, and they can have a normal white blood cell count sometimes. It's just that their normal is shifted downwards slightly. You can reassure the patients there's no increased risk of infection. So this is a graph of the distribution of the Duffy phenotype, which maps quite nicely with the distribution of malaria. So it's very common in northern. We see a lot of patients from the Horn of Africa, Eritrea, Somalia, Zimbabwe, but it is still quite common even going up into Egypt, as well as places like Yemen, Saudi Arabia, and Iran. And, you know, obviously it says that it's not common in Australia, but you have to take into account what your patient demographic is, because it's very common in the northern suburbs. So we know that if you've got a patient in front of you who's from one of these real hotspot countries like Congo or Eritrea, that the chance they have this is almost 100%. Similarly to before, I'm happy to move on to the last cytopenia or take any questions now. All right, so thrombocytopenia. So similar to the other, similar to neutropenia, we divide into mild, moderate, and severe. Really, patients only bleed when the platelets are less than 30 to 50, and even then, it's not really well correlated with the platelet count. Patients with ITP specifically don't usually bleed until their platelets are less than 10. And for patients, for example, with leukemia, we can do a bone marrow biopsy with the platelets being single digits, and most of the time they don't bleed. We see a lot of patients who've got slightly low platelets, like 120, 130 with bruising, and vast majority of time the bruising is not related to the mild thrombocytopenia. The impact of low platelets on hemostasis is generally not really apparent until the platelets are less than 75. And that kind of forms the basis for our recommendations for platelet transfusion in patients who are having surgery, for example, where usually we'll tolerate a platelet count of over 50 and say that that's adequate for hemostasis, unless it's really complex surgery like neurosurgery. Similarly, for anticoagulation, generally if the platelets are over 50, then we would say that standard antiplatelets or anticoagulation, if it is indicated, would be safe. There is an increased bleeding risk in the range of 50 to 75, but generally it's safe for most patients at that level. So there's a completely different kind of set of causes in an inpatient setting, but I'm just going to focus on stable outpatients. The common things we see are spurious thrombocytopenia, immune-mediated mechanisms, the most common being ITP, but lupus and antiphospholipid syndrome, hypersplenism and liver disease, post-infective, medication-related, pregnancy causes of thrombocytopenia. And then right down at the bottom, you have the rare things that we see like congenital thrombocytopenia syndromes and bone marrow disorders. Similar to neutropenia, there are a lot of medications that can be associated with thrombocytopenia, specifically penicillins, although it tends to be intravenous penicillins that are given in hospital rather than your amoxil and things like that. As I said before, valproate's notorious for causing a mild thrombocytopenia, and you can get a thrombocytopenia after vaccination. Just a note on spurious thrombocytopenia. This is hard for you because often you will get the report released with the platelet count being slightly low, and then at a later date, someone will have a look at the film and redact that platelet count because of this feature. So essentially, it's purely an in vitro phenomenon, which means it occurs when you put the blood in the tube, where when you put the blood in the tube, the platelets stick together, and that leads to a false underestimation of the platelet count. We can try to overcome this by collecting in a different type of tube, so a citrate tube instead of an EDTA tube. It sometimes works. And even if it can't be, sometimes you just have to accept that if the patient's not bleeding and there's clumping, but they look like they're normal in number, the lab may not be able to give you an accurate platelet count. We do see this occasionally, but often we can overcome this by using a citrate tube. So similar to all the other cytopenias, look at the platelet count over time. Often we see people who just sit on the lower end of normal, 130 to 160, sometimes they're 140. And if it hasn't changed a lot over time, it's probably not going to be anything to worry about. I would do viral serology in most patients. I also do, especially, it depends a little bit on your patient population, but in the migrant population in the northern suburbs, there's very high prevalence of Helicobacter pylori, and H. pylori is associated with an immune-mediated thrombocytopenia via a molecular mimicry mechanism. So in the absence of anything else of concern, I will often just test for that and treat it. It doesn't always make the platelets get better though. Often we would then do autoimmune serology, obviously your liver function, and examine for splenomegaly, or if that's challenging in the patient or you're not confident, in abdominal ultrasound to assess for portal hypertension. So if you've got a patient who's got a mild thrombocytopenia that's isolated, no problems with their other parameters, and it's stable over time, so either historically or with subsequent blood tests, I'm often comfortable, well, I'm comfortable observing them, and I think you should be too. On the other hand, if it's progressive, there are other unexplained cytopenias or macrocytosis or an abnormal film or unexplained splenomegaly. And then when the platelets start to get less than 100, especially 75 or 50, that is the kind of often the point where we try to make a diagnosis. If they're not requiring anticoagulation, it's less important. But if someone's sitting in the 50 to 75 range and we don't really have a cause and they need anticoagulation, that might be a situation when we try to figure out what's going on with a bone marrow biopsy. So this is my third case. So this is a patient who's completely well, and I actually didn't see her at this point in time. This is her GP, did blood tests at some point prior to seeing me. So obviously the red cells are normal. There's a very slight macrocytosis and platelets are very slightly low. I can't remember exactly how long they repeated it, but I would have just repeated it in 3 months' time. But I would say, oh, the macrocytosis is a little bit interesting. So then the second blood test, you can see that even though the hemoglobin's now normal, it's dropped 2 points. The macrocytosis is a little bit more pronounced and the platelets are actually a little bit better. I don't think I saw this patient at this point in time, so presumably it was just monitored a few months later. And then, she's clearly now got a macrocytic anemia, worsening thrombocytopenia. And then again, the next time, she's starting to get some anisocytosis with that increased red cell distribution width and worsening thrombocytopenia. So the red flags in this case is it's clearly progressive. So every time you do the blood test, the red cells are getting worse, the platelets are getting worse, and thankfully her neutrophils are fine. So in this case, you need to do a bone marrow biopsy, which is a minor procedure that we generally do under light sedation. It's very rare that we need to do this for most first-field clinic patients because we see a lot of mild isolated cytopenias, and bone marrow biopsy is not a great test for those patients. But we have had a few patients, for example, in the border regions where we've needed to do a bone marrow biopsy, and the options we can offer are to bring them down to Melbourne and do it publicly at Northern, to do it privately if they're insured, or if we have contacts with the local public hospital, we may be able to organise it that way, or suggest that you refer them to public hospital for a haematology outpatient appointment. So in this particular case, the bone marrow confirmed a diagnosis of myelodysplastic syndrome, a particular subtype called MDS with low blasts and SF3B1, and is just being observed. And the point I wanted to make with this case is, even though those numbers and the progression of things you look at probably scares you, at the end of the day, it wouldn't have made any difference if I'd seen the patient back here. It became apparent over time. We did a bone marrow biopsy and the patient's still being observed. If the patient's well and they've got safe counts, there's no need to panic about early diagnosis of a hematologic problem, except for perhaps something like multiple myeloma, because it will become apparent over time, and we can treat it at that point in time. So observation is often a very good strategy for these very mild cytopenias and just seeing what happens over time. So in summary, most mild isolated cytopenias are a benign finding that we can observe to observe the trajectory. And the most reassuring thing for me is when I look back and it's been there for many years. In unexplained anemia, it's very important to try to exclude myeloma with the paraprotein and protein electrophoresis and serum-free light chains. And in any abnormal FBE, the things that mean that a bone marrow disorder is more likely if there are 2 or more cytopenias, or definitely if there's pancytopenia, obviously if there's an abnormal blood film, but if it's progressive over time and if there's associated macrocytosis. Regardless, observation with serial FBE is a very reasonable option, and most serious cases will become apparent over time. That's the end of my presentation.
Thanks, Matthew. There are 2 questions in the chat, and we'll open up as well. You've addressed the first one, but I'll just read it out as well, which is from Farhan. What do you recommend in terms of monitoring for thrombocytopenia, leukopenia, if the patient's asymptomatic? You've sort of answered that in that, yeah.
It kind of depends. It's hard to be very prescriptive because it depends a lot on what you know about the patient. So if you can look back and you can see that their neutrophils are always in a certain range, and now they're just still in that range, I would just do it once per year. But if you've just seen them for the first time and the neutrophils are 1.1, you probably need to repeat it in, say, 1 to 2 months, just to make sure that this isn't something evolving. But then once you get a sense of their trajectory, every 6 to 12 months would be appropriate. Very rarely even though I say a lot of the cases are benign, we do see patients like that last patient who have a very mild cytopenia and it does develop into something. And the cytopenia is probably a sign of early, what we call clonal hematopoiesis. But, it will become apparent over time. And aspirin in general is not recommended in thrombocytosis unless you have a diagnosis of a myeloproliferative disorder. So in essential thrombocytosis, the thrombotic risk is not just because the platelets are elevated. It's actually a lot more related to the specific mutation, and particularly the presence of the JAK2 V617F mutation, which via a very complex mechanism increases the risk of thrombosis. So if you just have patients and you're not really sure why they've got thrombocytosis, or you think it's because they're a smoker or something like that, you shouldn't really be putting them on aspirin unless they've got another reason to be on it. Any familial relationship between thrombocytopenia in certain races? There are very rare genetic associations with for thrombocytopenia, but they're not as easily demonstrable as ethnic neutropenia, and we currently don't really have great tools to look at them in terms of routine genetic testing unless they have a true thrombocytopenia with a bleeding phenotype. So I'm sure there are genes that cause a slightly lower than normal platelet count, but we don't routinely test for them unless they have a clinical consequence. So that would be cases like May-Hegland syndrome, for example, where there's a macro thrombocytopenia that's associated with a bleeding phenotype, and we look for a specific gene.
Anyone have any other questions, feel free to unmute, or if you wanted to write in the chat, if that's your preference.
I'm happy. I'll keep talking if you want.
Yeah, please. And then I'll just get the CPD registration document up.
Because we've got 10 minutes. Just in terms of elevated blood counts, some similar reassuring things. So things that cause elevated hemoglobin, smoking, even in the absence of lung disease, smoking, especially shisha smoking, and cannabis causes an elevated hemoglobin. We also increasingly are seeing mild erythrocytosis or polycythemia with SGLT2 inhibitors. And I know that probably all of your patients are on that now. So just be aware that that can cause usually a mild to moderate polycythemia, and it's usually considered benign. And then obviously you have things like testosterone. But you still have to think about whether they could have a primary polycythemia, such as polycythemia vera. Mild neutropenia, we sometimes just see as a benign finding, often in middle-aged women who've got obesity and cardiometabolic syndrome, just as a marker of chronic inflammation or systemic inflammation. And often we look back and it's been there for many, many years. Similarly with smoking, especially cannabis, can cause a neutropenia and a monocytosis as well. The lab should pick up on most. The thing you think about with neutropenia is something like chronic myeloid leukemia, but the lab should pick up on that. And then similarly with.
Awesome. Do you mind just jumping down a few slides? I think to slide 46, just where the QR.
Oh yeah, the CPD. Can you see that?
Yeah, if anyone wants to scan or link, but if it doesn't work, just email us. But
yeah. And then same with thrombocytosis. I mean, you have to think about essential thrombocytosis, but the commoner causes are iron deficiency, infection, inflammation. And again, we do see chronic, and I've spoken to one of the GPs on here who sees a lot in her Indigenous patients, I believe, in type 2 diabetes, metabolic syndrome, often just this low-grade thrombocytosis of 450, 470, that is just a marker of chronic inflammation from those conditions. The question, when to order lymphocyte surface markers or flow cytometry, it's mostly useful if you have a lymphocytosis to try to figure out what the lymphocytosis is, because it can be clonal, so related to a lymphoproliferative disorder, either CLL or monoclonal B lymphocytosis, which is the precursor to CLL. But similar to those other things, we do see a lot of lymphocytosis that's due to low-grade inflammation from smoking or metabolic syndrome as well. Otherwise, lymphocyte surface markers are not a great test just to screen for things like neutropenia or lymphadenopathy or weight loss or things like that. But it's mostly useful if there's a lymphocytosis or an abnormal blood film.
That sounds fantastic. Thank you very much. I think I'll just pop the link in the chat to the survey for feedback. And otherwise, any last questions? Otherwise, thanks, Matthew. That was very, very useful when you're kind of just sitting there with, it's sort of like there's low platelets, but it's not too low, but you're a bit worried because it's not really something I know too much about. Do I refer? So I think, did someone put their hand up for a second there? No, maybe it was a clapping signal. And then I think you're right, the virtual clinics, whether it's that e-consult, a quick question, or just walking through it with the patient. Very useful.
So these mild cytopenias are the patients who unfortunately just linger on the wait list at most public hospitals. So the virtual clinic is a great option, especially if they're very anxious about it. We're more than happy to see them and just reassure the patient.
Thank you, everybody.
Or provide some advice on when and how to follow up the patient.
Yeah, absolutely. I think it's just that reassurance sometimes of being able to bounce the idea off someone when you're feeling a bit stuck in primary care or anywhere is very valuable. And I think no one else had any other questions. Do you mind just jumping? Oh, is there, Farhan, I think you have a question.
Yeah, just a quick one. I put that on my chat as well. So basically, when to order the lymphocyte surface marker for somebody with high white cell counts?
Yeah, so it's lymphocyte surface markers or flow cytometry only look at the lymphocytes. So it's mostly useful if there's actually a lymphocytosis to see what the cells are and see whether they're clonal, for example, in CLL or a lymphoproliferative disorder, or non-clonal, or if there's abnormal blood cells, abnormal lymphocytes on the blood film. It's not really a great test just because if the white cells are high, but there's no lymphocytosis, like if the neutrophils are high, lymphocyte surface markers are not going to help because they don't look at the neutrophils, they only look at the lymphocytes. Nor is it a good test for kind of just generic things like weight loss, or sometimes we order it for lymphadenopathy, but honestly, it's very rarely that useful. Does that answer your question? I'll presume yes.
Great. Do you mind just jumping to the next slide?
Yes.
47. Thank you. And so thanks everyone for your time. In March, on Tuesday the 17th, there'll be a talk around supporting patients and families of patients who are looking to make an advanced care plan, especially in primary care, and any questions that you might have around that. So Dr. Hazo will be talking. And if there's any other feedback for us, we're always very keen to hear from you. And once again, please jump on the website, have a look at the clinics available, see if it suits you to do that case conference model, if it'd be helpful to have a few team members involved, or you can do the more a one-on-one with the patient there as well. And please do have a look at that new service which has just gone live this week, the consult, sending those messages. We're looking at that kind of de-identified messages of just, I found this, what do you think? And we'll try to get back to you within a few days with some advice, and can always recommend organising an appointment with us if that would be probably the best way forward. So thank you again, and I hope you all have a lovely night. Thanks, Matthew.
Thanks, everyone. Thanks for coming.